that of young Odisha. They are the torchbearers of tomorrow with newer ideas, youthful energy, and promise of a bright ophthalmic future for OSOS. Our first speaker is Dr. Praveen Kumar SUBUDHI, and meanwhile the next speaker should also be ready. Over to you, Dr. Praveen.
So at the outset, I would like to thank OSOS and AIOS for giving me this opportunity, and especially Sarmishta Madam for keeping me young at the age of 40s. So how many of you are in private practice? Can I have a hands up? Private practice. So we all know what are the problems associated with our private practice. We have a lot of financial pressures, we have regulatory pressures, we have competition and patient volume increase year on year, and human resource management. So there are so many things comes to our head, and so much of pressure is there to take care of our practice. And the only thing we can help in growing our private practice is cataract surgery, as we all know. Cataract and refractive is the bread and butter of ophthalmology, and other specialties can only add to your passion, but it cannot be the primary thing which you can perform in your practice. So what is the reality, the sad reality we have in keratoplasty or a transplantation? It's the duration of the surgery. And we need to know there are always associated risks of rejections and failures, which we need to accept like any other transplant. And we need to have a regulatory body to establish so that you can perform transplantation at your center, that is HOTA or an iBank association. The problem in any private practice is we have a very high stakes scenario where achieving the desired outcome is expected with certainty, but yet any deviation from this outcome are not tolerated. So that is the thing, sad reality we need to understand. And the full thickness keratoplasty, which is a classical keratoplasty or transplantation which we used to perform, because this transplantation has become outdated, has come in the backbench because it has so many graft rejections, because of the multiple sutures, there may be suture infections, suture related astigmatism, and these are the problems. Patient doesn't have a very good optical outcome following the procedure. Hence, we have to upgrade ourselves as a cornea surgeons to endothelial keratoplasty, which can be broadly classified into a decimet stripping endothelial keratoplasty, ultra thin DSEC, and the new generation, and the new generation surgeons perform a DMEC, which is decimet membrane endothelial keratoplasty. And we need to know where are the cases where we perform these endothelial keratoplasty. That is, the PBK is the pseudophakic bullous keratopathy, FECD is the Fuchs endothelial corneal dystrophy, failed grafts, ICE syndrome, that is iridocorneal endothelial syndrome, and CHED syndrome, and these are basically broad indications where we perform an endothelial keratoplasty. The advantages of endothelial keratoplasty over a classical penetrating keratoplasty: it's a sutureless procedure, the post-op visits are less, and the risk of rejections are drastically reduced compared to a full thickness penetrating keratoplasty. But the problems which I faced when I started this endothelial keratoplasty, I was relatively new because during my fellowship I did not had an opportunity to perform endothelial keratoplasty. So directly I had to jump to perform endothelial keratoplasty in my private practice, and it has a very steep learning curve, and there is an unpredictable journey. I'll show you. In this case, it's a very interesting case. This is a case of a DSEC which I performed in a failed graft. After removing the thick hypertrophic epithelium, I had some view of the antechamber. So now I had to stain the chamber or the decimet membrane with the trypan blue, and you need to just strip the decimet membrane. Here, mind you, in these cases, the decimet membrane is very tight; it's very difficult to remove. So after doing the lenticule, performing the lenticule, you introduce this lenticule into the anterior chamber. After putting the air, the oops movement happened. I could not see the lenticule. Because it was a post cataract surgery and the lens was little bit subluxated and there was no proper posterior capsule, the lenticule was almost in the vitreous chamber. So now I have to open up the antechamber and I have to pull the lenticule out of the vitreous to the antechamber, and finally I could achieve the tamponating the lenticule to the cornea. But after this many manipulations, anybody can think this graft is bound to fail. But somehow it became successful. But this is the unpredictability. So another case, so there are risks of failure associated with these endothelial keratoplasty, and when you have failure, you feel dejected, you feel disheartened, and you feel like quitting the procedure, because there is a risk of graft losses, there is a risk of graft failure, and the unpredictable journey which I was telling. So these are two interesting cases. In this case, I performed a DSEC, and it took 3 to 4 weeks for the graft to clear, and finally it became successful. But another case, the surgery went very well, successfully went. It was a pre-cut graft and everything went well, but within 4 weeks, the graft went to a primary graft failure. So this is the unpredictable journey you have. You can have success, but the success and failure can be known only after 2 to 3 weeks. So if you have a primary graft failure, then you can again go for a removal of the old graft and replace it with a new lenticle. Finally, this patient had to suffer for another 6 months. After 6 months only the patient could see. The best part is the patient was loyal to me, and it continued to me, and did not went to LV Prasad, it came to me only. So finally the journey continues, where the DSEC, where we have to upgrade yourself from DSEC to DMEC, and that is the future for every cornea surgeon, and it is the DMEC which gives the patient the best visual outcome. And here just the video, this is also an oops moment for me here in this case of phaco DMEC. I'll just show you what's the oops moment was there. So I introduced the scroll into the antechamber, and as I was unscrolling the scroll, I could see the scroll was opposite, was inverse. So I had to deepen the chamber, and while deepening the chamber, you can see the oops moment, the lenticle came out, the scroll came out. Again, I had to reload it and had to put inside the antechamber. Finally, the patient did well. Hopefully, as I said, it is again a very unpredictable journey. So to conclude, in summary, endothelial keratoplasty has a strong and expanding role in private practice due to its advantages over traditional transplantation methods, the potential for improved satisfaction, and ongoing advancements in surgical and donor tissue technologies. As more private practitioners will adopt these techniques, the scope for endothelial keratoplasty is likely to continue to grow, benefiting both surgeons and patients alike. So thank you for the kind attention.
Thank you, Dr. Praveen. So our next speaker in line is Dr. Chittaranjan Mishra.
Slide is ready. Question for him? None?
Next.
No. Praveen, when you found that the patient has not gone to LV Prasad, were you particularly happy or unhappy?
I don't know, sir. I was unhappy because the patient keeps on coming, and that day I was. I finally became happy.
Praveen, actually, any new procedure which we have not learned is a difficult procedure to begin with. In private practice, there's nothing extra. There are short courses available where you can go and get the training done. My question is, do you need any extra equipments to make sure that your journey becomes smooth?
Yeah, if you have the luxury of IOCT, like intraoperative OCT, that is the biggest boon you can have, because on table you can see the scroll and you can manipulate, and if you see there is an inversion, those things can be done, because particularly DMEC scrolls, there is a particular orientation. It has to be like this, it should not be like this. So those scrolling things, whilst unscrolling, whether the scroll is upwards or downwards can be known while with intraoperative OCT. So that, yes sir?
Okay, thank you, Dr.
No,
Praveen.
but Praveen, you just that why letter away from that luxury, because you already have the Lumira 700. Why don't you get the IOCT?
No sir, it is not compatible to Lumira I. It is compatible to Lumira.
You have the 700, I believe. You don't have the 700?
700 is with Retina, sir, not with me.
Oh, acha, so there is the differentiation. The fractionation, so to speak.
Your application to your reserve bank.